Thank you, Chairman, ladies and gentlemen, and thanks for asking me to talk on this subject. I'm grateful that the scene has been set by many of my colleagues in this session already. This is a note of my research funding. You've already seen this presented in different ways, but I just thought I'd start by saying that I've been asked to talk about rectal cancer, localized disease. What's the role for targeted agents? I mean, I could probably give this talk in 30 seconds, but I'm going to review some of the evidence. I mean, certainly if we're looking at patients that we might want to target, we would be following the general advice that we've received already. That is to say, you're not going to start investigating targeted agents in patients with essentially good prognosis disease. I think we have to look at the patients where otherwise they have a relatively poor prognosis. And particularly with the more advanced tumours that you heard about, there is a window of opportunity for targeted therapies. And for this reason, there have been a number of clinical trials evaluating drugs for these patients. Just to reiterate the points that have been made, and this slide summarises the larger trials that have been conducted in rectal cancer, showing that 5-year overall survivals range from 64 to 80%. Path CR rates range from 8 to 21%. As we know, this is a function of inherent sensitivity to chemoradiation and also the stage of the disease, the bulk of the tumour. And local recurrence rates also range from 4 to 8%. But as you've also heard, there's still a significant issue around distant disease. 19 to 30% of patients will develop metastatic disease recurrence. Now, you've already heard earlier this morning about the use of checkpoint inhibiting therapies in colorectal cancer. But what we can say here is that, at least for the purposes of those agents, that rectal cancer can generally be regarded as similar to non-hypermutated colon cancer. And we know this anyway, that most of the hypermutated tumours are actually arising from the right side of the colon. So I suspect that until we have better ways of delivering immunotherapy, the rectum's not going to be the primary organ for targeting. So we know that the hypermutated forms have an increased response to immunotherapy, and we saw the very elegant presentation earlier this morning of showing that these patients may benefit or do benefit from immunotherapy. Now, one of the other points to make is if we look at the two most widely used targeted agents in colorectal cancer, being cetuximab, panitumumab, bevacizumab, in the advanced disease studies, there's no obvious evidence that tumours with metastatic disease that have arisen from the colon are any different to tumours where the metastatic disease has arisen from the rectum. So the response in this particular study, the PRIME study, was the same. And actually, when you look at anti-angiogenesis, and this is the AVAX study, and analysing the benefits of anti-angiogenic therapy in metastatic disease based on the primary site, there is no difference. So from what we can tell from advanced disease, if we use these targeted agents in rectal cancer localized, they might have the similar beneficial effects. So using targeted therapies as radiosensitizing agents in locally advanced rectal cancer, because essentially we've got a number of areas where we can use the targeted agents. We can combine them with chemoradiation as part of a chemoradiation strategy. or we can combine them with neoadjuvant chemotherapy, and we'll show some of those data, or you can combine them throughout the whole treatment pathway. In fact, there are relatively few studies. They're all phase 2, combining targeted therapies with locally advanced radiotherapy. And the take-home message from these studies is that the path CR rates range from 5 to 26% with cetuximab chemoradiation. And with bevacizumab combined with chemoradiation, they range from 13 to 32%. So nothing there is a particularly strong signal, I would submit, based on the path CR rates that have been reported in clinical trials where there has been no targeted agent used. I mean, one of the questions that's come up, and those of you who saw the esophageal data that we presented yesterday, is path CR rate in any event might not be the best goal. And you heard earlier on during this presentation, you're combining TRG 1 and 2, whether you define it by MR or histopathology. Those patients tend to do similarly well. And then the people with the more advanced TRG 4 and 5 do badly. And so at least there's probably a subset there we can look at. So I think the enhancement of tumour radiosensitivity by cetuximab and bevacizumab may not be as relevant as suggested in some of the preclinical studies. And I get a feeling that there's not a lot of mileage in this, but I'll show some of the evidence. So then looking at targeted therapies in conjunction with neoadjuvant therapy. And you've already heard that this is a strategy that can be employed. It's not actually proven from randomized studies that it benefits patients, but clearly it makes sense that if you have a patient where you might otherwise be offering systemic chemotherapy after surgery, it would make sense to at least consider offering systemic chemotherapy plus a targeted agent before surgery. And my colleague presented the results of the Expert C study. And this was a trial that we worked collaboratively with colleagues in Spain and also in Scandinavia. It was a study in which patients were defined by MRI, thanks to Gina Brown, and these patients were defined as having high-risk tumours, and they were randomized between chemotherapy, chemorad, surgery, then more chemotherapy. So we were taking a fairly aggressive approach in this group of patients, and the question we were asking was, would cetuximab add anything, at least in this trial, to, for example, path CR rate? And in fact, one of the problems we had with the study was it was designed before the data for RAS sensitivity, or before the data showing that you had to be RAS wild type to be sensitive to cetuximab. So the power of the study was diluted. We did try and extend the trial, but it didn't prove possible. And what you can see here is, this is after CAPOX-C. And this is after CAPOX. So if you're thinking about, does combining a targeted drug with chemotherapy increase response rates? Well, this trial in the RAS wild type subset did in fact show a higher response rate, 50% against 71%. So that's quite a useful piece of information. Of course, when you dial in the chemoradiation, your response goes even higher. But actually, if we look at the path CR, and this includes people that had a complete response and then didn't have surgery, we're still down here in the 10% level. Now that may be because these had advanced disease. It may also be because we scrutinized these samples very closely. It was a small phase 2 study. Just to show the outcomes here, the 5-year survival outcomes, there's no significant difference between the two, although there was a trend towards improvement with the patients who received cetuximab with the chemotherapy. This is pretty hopeless, this, I'm afraid. But the red is the cetuximab. But that's non-significant. So there's nothing here to change clinical practice, but there's something here that in fact shows a bit of a signal for combining chemotherapy with cetuximab as part of a neoadjuvant strategy in patients who have RAS wild-type tumours. So what about bevacizumab? This is really very interesting data showing that if you combine bevacizumab with chemotherapy, that you may increase response rates. But one of the key areas we need to be concerned with, particularly bevacizumab in patients who are having anterior resections, is the risk of an anastomotic leak. And I suspect that would be, this will turn out to be a significant problem with Bev within this particular context. And it means that if we are going to use bevacizumab as part of a neoadjuvant strategy, consideration will have to be given to the timing of surgery, pre-treatment defunctioning surgery, and whether or not there would be a concomitant use of radiotherapy. Because these data contrast with the trial that I'm going to show now, which is the Memorial Sloan Kettering study of upfront chemotherapy with FOLFOX and bevacizumab. Again, these data were published last year in the JCO. I think that the notable feature of this trial is that, and it's a small phase 2, that the path CR rate is, next year we should get a different thing at the point. The path CR rate is 25%, and actually the local failure rate and the survival rates look extremely good. I mean, I think this is quite a highly selected group of patients, and you can see that they were excluding bulky tumours. These patients were at an MRI stage, but I would suspect they had good prognosis disease. But in fact, if you look at the North American study that's now been launched, it doesn't include a targeted agent. So whether that benefit that was reported in the Memorial Sloan Kettering study relates to bevacizumab is impossible to tell. Whether it was a function of these were relatively early tumours where you might expect to get CR, but they certainly show that if you give upfront chemo, you can get path CR rates, and thus the study design, which is essentially asking the question if there's a subset of patients where you can avoid chemoradiation. In tandem with this, there's the UK BACCHUS trial, the CI is Rob Glyn-Jones. And the nice thing about this trial is it's a very simple question, except both arms have bevacizumab. One's a chemo doublet versus a chemo triplet with a PET-directed evaluation of response. In this particular study, the primary endpoint is path CR, and I think that path CR on its own is probably not the best primary endpoint. I think we should be looking at Mandard 1 and 2, so i.e. patients who are getting a very good response to treatment. I also looked at the phase 2 studies that are beyond cetuximab and bevacizumab, and really there's a lot of trials out there that are very difficult to interpret. They are generally small phase 2 studies that really don't seem to me to show anything that is resoundingly over-encouraging. Small studies, path CR rates variable as we see throughout the literature. So in conclusion, I think that the first statement is that, and we've already heard that, the role for targeted agents in this disease is currently limited. I suspect that the best role for targeted agents will be in combination with chemotherapy rather than radiotherapy in patients who otherwise would be candidates for systemic treatment. I think that clearly caution is needed when investigating anti-angiogenic drugs, particularly combining with radiotherapy. And as usual, we need to look at identifying further biomarkers that can show a benefit from these approaches. Thank you very much.